Welcome to the next talk in the Covid-19 Pandemic Quality and Safety Tools. In this series, we hope to bring you patient safety theory and quality improvement theory so that you can continually improve care for the people that you treat. This is lesson number 5, with safety at the core and an overview of patient safety. I'm Dr. Peter Lachman, CEO of the International Society for Quality in Healthcare, ISQua, and also the lead QI faculty at the Royal College of Physicians in Ireland. I'm pleased to be here to introduce some basic tenets in patient safety that will help you do your day-to-day work in a safe way. René Alberti and Charles Vincent recently published a paper in which they stated that safety needs to be managed proactively. We cannot improvise, and right now there's a lot of improvisation going on. So in this talk, I'm going to try and translate safety theory to guide your day-to-day practice so that you will be able to provide safe care even in these trying times. Alberti and Vincent give 4 elements which I show on this slide about this moving to proactive management of risk rather than improvising and reacting to events. The first is very true of today, giving up the hope of waiting for things to return to normal and managing risk proactively. That means that we can't hope that things will all get back to the normal way we were working. In fact, then it was not as safe as we would like it to be. So we now need to look at the new normal, the current one while we have COVID infections, and the post-COVID normal, which will be very different. We have to accept that we can never eliminate all risk and hazards, either now or in the future. Healthcare is a risky business. We undertake risk to ourselves now when we're treating people who are highly infectious, and risk to patients when we treat them with medications, place them in intensive cares, have a higher risk of falls, delirium, pressure ulcers, and medication safety. These risks all remain now and in the future. So we have to accept that they are there and plan to diminish them by mitigating against the causation. So we have to understand in our clinical area, what are the expected problems and hazards? What can we expect to happen where we work, and what can we do to mitigate against the risk that we know is present? And finally, if we are going to solve this, in particularly these stress times and going forward, we require engagement and action at all managerial levels. That is from the HSE planning level to the executive teams in the hospitals, to the middle management, and right to the front line. Everyone needs to be involved. And as I go through the theories that we talk about in patient safety, you'll see that involving the front line is essential to come to the solutions. The safety system starts with individual responsibility. And individual responsibility requires us to ensure that we are acting safe at all time. Then what was called risk management is really incident management, understanding why things don't work and work well, and why they do work well. We need to apply a human factors or ergonomics approach. And I mentioned this in the first opening talk, and I'll come back to this shortly. This means we have to understand how our systems work, how we can make them reliable, how we can have situational awareness of what's going on so we can anticipate the future, and finally, how we can build resilience, which is often called safety too. So let's look at individual responsibility. This has 3 elements from my perspective. The first one is that people providing care need to feel safe, and people receiving care need to feel safe as well. Psychological safety is now regarded to be essential to ensure that we provide safety at all. And John Brennan will be talking about this in the next talk. It means that people are safe to raise issues, safe to know when things are unsafe, and safe to share their fears as well as their hopes. That leads us to being safe in all that we do. We need to consider this at all times and think about all our actions, all our different parts, whether it be from diagnosis, from prescribing, to administration of medications or any other care, to consider whether we are being safe, and being safe protecting ourselves. And finally, this means that acting safe is what we need to do. Safety shouldn't be something that we think about, it should be how we behave at all times. So individual responsibilities goes a big way. However, it's not sufficient. We need to have a management system that allows us to understand what works well and what doesn't. So we need to be constantly be aware of what could go wrong. And if things do happen, we need to try to investigate them in real time. And we can do that with a process called the 5 whys, asking a question 5 times. So for example, if there's a prescribing error, we could ask the question 5 times. Why was there a prescribing error? Was the trainee or the doctor involved able to prescribe? Did they have the right equipment, the formulary, the calculator? Were they interrupted, etc., etc., until we get to the root cause? And once we have that, we need to fix the problem in real time. For example, create a safe area where people can prescribe, an area which is quiet, where there can be no interruptions, where all the equipment is available in order to prescribe. That means we'll have to learn, and once we learn, we need to spread the learning so that we are constantly aware of being safe. So incident management is a very important time, and it's not the responsibility of the risk management team, but rather the responsibility of all frontline staff to constantly look at how they're behaving, how they're acting, and seeing when things work well and do not. And one can also investigate good behavior, good outcomes, as well as near misses. I refer to the SEEPS model, social engineering for patient safety, which was developed by Pascal Carrion and her team. And here we look at the work system, the processes involved to get the outcomes, and the outcomes we achieve with a feedback loop, so that we're constantly adjusting the work system. Now, this is very important for all of you in the clinical front line, is that on a daily basis, one can assess whether the work system is safe. This is in real time. So one would look at the personnel one has, the doctors, the nurses, has everyone the skills in order to undertake the tasks required? Do they have the right technology and tools in order to undertake the tasks and complete them? What's the team spirit like? What's the organization like? Do we have the right culture? And what's our environment that we are working in? Now, of course, these are not all ideally safe, and at all times we'll be able to assess and mitigate in each of these areas to ensure that we can provide safety. Then we have the processes, the professional work, the way we do things, and the way we work with patients to ensure that we are safe. You could apply this to taking on your PPE and taking it off. Do we have the right processes, and do we follow it in a stepwise manner in order to ensure that we do not contaminate ourselves or others? And finally, measuring the outcomes, both desired and undesirable, so that we can learn and that we can understand what's happening and change the work system to ensure that we achieve the right outcomes. So human factors is an incredibly important part of the way we organize our care. And I think that if you apply to every action that you do and look at how your work system is working, then you can really aim to high reliability. And high reliability is what we really want to do. We're getting the right care to the patients at the right time with minimal harm at all, given the fact that it is a highly risky business to provide care right now and in the future. To do that, we need to study even the smallest errors, because that's a symptom that something is wrong. For example, if the prescribing form is not fully correct, then that could be a sign that there could be a bigger error going on. If you have not put your PPE on correctly in 100% of the way, gone through the right moves and right stages, then that could mean something could go wrong. So the smallest things are more often the most important. We often call these near misses, and studying the near misses will help us make sure that we do not harm people. That requires us to pay attention to what's happening in the front line. For those in management positions, this is very important to ensure that you listen and hear and see where you need to change things, because that is where you'll get reliability. To do that, you mustn't simplify. You have to listen and get a variety of perspectives. Everyone's viewpoint is important. Finally, you get to the learning phase, in which you're able to learn from events, both good and bad, and bounce back so that the front line, who know the answers, are continually learning and improving the process. In our observations of what's going on now with COVID-19 around the world, clinical teams are constantly learning. They are applying this high reliability, often without the theory. But if you take these 5 steps of high reliability from weak and cyclic and apply them in real time, then you're going to obtain high reliability without knowing that it is so difficult. This leads to situation awareness, which is another way of getting things forward. This is means of gathering information, recognizing and understanding, anticipating what will happen, and having perception, comprehension, and projection, so that we can get to a decision, action, and a worldview of what's going on. I'll be talking about this later when we discuss situation awareness in one of the next talks. The last element is about resilience, often called safety 2. And Eric Holnagel, who brought this forward as a theory of resilience engineering, he says that the variability that completed the job safely one day may be the same variability that is blamed for the accident on the next. We just need to understand why this is so. So to be resilient under all conditions, both predictable and unpredictable, we will need to look at that variability and study it from a positive rather than from a negative point of view. So those are the theories of patient safety. We need to constantly learn from what's going right, what's not going right, look for reliability by studying the human factors approach of the work system and processes. I'm finally going to end off with something I hope we'll take forward going in the future. In this pandemic, we have cut through red tape. A key tenet of high reliability is making it easy to do the right thing and making the right thing easy to do. COVID-19 gives us an opportunity to really re-examine our regulations, re-examine the way we organize things in the past, and evaluate whether they meet the above criteria. I hope this has been useful to give a framework for patient safety. We are going to go into greater detail in each of these elements going forward, and our next talk will be on psychological safety by John Brennan. This is Peter Lachman signing off. Thank you for listening.